Hello, everyone, and welcome back to Study Nurse IQ. I'm Jenny. Today, we're diving deep into one of the most important topics in nursing pharmacology: diabetes medications. We'll break down the drugs used for both type 1 and type 2 diabetes, how they work, what to watch for, and key NCLEX style facts. Stick with me till the end because I've got NCLEX style questions to test your knowledge. So let's get started. Part 1: Understanding diabetes and diagnosis. Before we talk about the medications, let's make sure we actually understand what's happening in the body. Diabetes is diagnosed by measuring blood glucose levels in A1C. That's your average blood sugar over the past 2 to 3 months. Now, let's go over the key diabetic values you need to know for a diabetes diagnosis. Fasting plasma glucose, 126 milligrams per deciliter or higher. Oral glucose tolerance test, 200 or higher. A1C 6.0% or higher. Random glucose, 200 or higher. Values for prediabetes: fasting glucose between 100 and 125. Oral glucose tolerance between 140 and 199. A1C between 5.7 and 5.9%. And here's a quick A1C trick. Notice how the jump between each percent is roughly 28 points? A1C of 6 equals about 126 milligrams per deciliter. A1C of 7 equals 154. A1C of 8 equals 183. A1C of 9 equals about 212. Who should be screened? Adults who are overweight or obese, BMI 25 or more, or 23 for Asian Americans, with additional risk factors. Everyone starting at age 45, especially if overweight. Kids or teens who are overweight and have at least 2 risk factors for diabetes. Screening early saves lives and prevents long-term complications. Part 2: The difference between type 1 and type 2 diabetes. Let's clear up the difference between type 1 and type 2, because this is always on exams. Type 1 diabetes, autoimmune condition. The body's immune system destroys pancreatic beta cells, produces no insulin at all, requires insulin for survival. Common signs: the 3 Ps: polyuria, urination; polydipsia, thirst; and polyphagia, hunger. Children develop it suddenly, adults more gradually. Type 2 diabetes. The pancreas still makes insulin, but the body can't use it effectively. That's insulin resistance. Over time, insulin production decreases. Symptoms: thirst, frequent urination, fatigue, and weight loss, progressing slowly. Now that we understand the basics, let's get into the medications. Part 3: Pharmacotherapy, insulin. If you're treating type 1 diabetes, insulin is non-negotiable. Many type 2 patients will need it eventually too. Insulin is categorized by how fast it starts, when it peaks, and how long it lasts. Rapid-acting insulin. Examples: Lispro, Humalog, Aspart, Novolog, Glulisine, Apidra. Onset 5 to 15 minutes. Peak 30 to 90 minutes. Duration 3 to 5 hours. Tip: think rapid equals right before a meal. Short-acting insulin, regular. Onset 30 to 60 minutes. Peak 2 to 4 hours. Duration 6 to 12 hours. This is the insulin of choice in emergencies like DKA because it can be given IV. Intermediate acting. Onset 1 to 2 hours. Peak 4 to 12 hours. Duration 12 to 16 hours. Remember, MPH not very fast, not very long. Long-acting insulin. Examples: Glargine, Lantus, Detamir, Levemir, Degludec, Tresiba. Onset 1 to 2 hours. No true peak. Duration up to 24 hours. Provides a steady blood sugar baseline, usually given once daily. Insulin dosing and complications. Insulin doses are individualized. Some use a basal bolus system, long-acting insulin as the base, and rapid insulin with meals. Hypoglycemia, when blood sugar drops below 70 milligrams per deciliter. Causes: skipping meals, over-exercising, taking too much insulin, or illness. Treatment: follow the rule of 15. Give 15 grams of carbs, wait 15 minutes, and recheck blood sugar. If the patient is unconscious, give IM glucagon or IV glucose. Diabetic ketoacidosis, caused by lack of insulin, leading to fat breakdown and ketone buildup. Signs: deep breathing, Kussmaul respirations, dehydration, fruity breath. Treatment: IV fluids and IV regular insulin, no exceptions. Part 4, non-insulin anti-diabetic agents. 1-biguanides, drug name Metformin, glucophage. First-line treatment for type 2 diabetes. Decreases glucose production by the liver. Increases insulin sensitivity. Decreases glucose absorption in the gut. Bonus, may help with weight loss, can lower A1C by 1.7%. Always check kidney function. 2 sulfonylureas, glimepiride, glipizide, glyburide. Stimulate insulin release from the pancreas. Main side effect, hypoglycemia. Also causes weight gain. Avoid in older adults or pregnancy. 3 thiazolidinones, pioglitazone, rosiglitazone. Improve insulin sensitivity. Avoid in heart failure or liver disease. Fun fact, can restore ovulation in women with PCOS. 4 alpha-glucosidase inhibitors, acarbose, miglatol. Block carbohydrate absorption, slowing sugar spikes. Side effects, gas, bloating, diarrhea. Avoid in bowel diseases. 5 meglitinides, repaglinide. Take 30 minutes before meals, skip dose if skipping a meal. Main risk, hypoglycemia. 6 SGLT2 inhibitors, canagliflozin, dapagliflozin. Block glucose reabsorption in kidneys, sugar exits in urine. Bonus, protect heart and kidneys. Avoid in severe kidney disease, GFR less than 30. 7 amylin agonists, pramlintide, Simlin. Used with insulin, slows digestion and reduces appetite. 8 DPP-4 inhibitors, sitagliptin, saxagliptin, linagliptin. Prolong GLP-1 action, increase insulin release after meals. 9 GLP-1 agonists, exenatide, liraglutide, dulaglutide, semaglutide. Boost insulin, slow digestion, and promote weight loss. Avoid in patients with thyroid cancer or pancreatitis. Part 5, lifestyle modifications. No diabetes management plan works without lifestyle changes. Eat balanced meals with moderate carbs. Get at least 150 minutes of exercise weekly. Lose 7% of body weight and maintain it. Stop smoking. Now let's put your knowledge to test with some NCLEX-style practice questions. Question 1. A 23-year-old patient has a fasting blood sugar of 143 milligrams per deciliter. What's the most appropriate plan? A. Recommend 150 minutes of exercise weekly. B. Discuss diet changes. C. Start oral medications immediately. D. Teach urine glucose testing. Answer A and B. Rationale. Lifestyle modification is the first step. Meds come next if needed. Question 2. When should repaglinide not be prescribed? A. When a patient has a fasting glucose of 95. B. When a patient A1C is 5.5. C. When a patient is NPO for colonoscopy. D. Post-meal glucose 185. The correct answer is C. Rationale. Repaglinide must be taken before meals. Skip dose if not eating to avoid hypoglycemia. Question 3. Which drugs are safe for diabetes during pregnancy? A. Acarbose. B. Glipizide. C. Insulin. D. Metformin. E. Pioglitazone. The answer is C and D. Rationale. Insulin is safest. Metformin is an accepted alternative. Thank you for joining me for this comprehensive overview of diabetes pharmacology. If this video added value to your nursing journey, head over to the Study Nurse IQ YouTube channel and click subscribe, and I'll see you in the next video.